Welcome to the Explore Global Health podcast. I'm Dr. Rob Murphy, Executive Director of the Havey Institute for Global Health here at Northwestern University Feinberg School of Medicine. My guest today, Dr. Lifang Hou, has spent much of her career trying to understand environmental and lifestyle risk factors that lead to chronic disease and cancer around the world, and how early interventions may help prevent these diseases. She is Director of the Center for Global Oncology here at the Havey Institute and Professor of Medicine and Pediatrics at Northwestern University Feinberg School of Medicine. Today, we're going to discuss her career journey from early years in China and her training as a physician to her work building global cancer prevention programs and training the next generation of researchers around the world. Welcome, Lifang.
Thank you, Rob, for having me.
Let's start at the very beginning, where you were born and raised in China. Tell me about your early years, what your childhood was like, and how did you get set on your path for a career in medicine?
Rob, I grew up in China. My mom was a physician, so I have seen her always treating patients, but I was not interested in being in medicine at all because I saw her busy schedule, always someone come to get her to go to their home to treat them. I was really interested in being a journalist. However, when I was in high school, I was actually only 16. And because the system in China, we can go to medical school right after high school. So my father asked me to apply for medical schools. I was like, no, I'm not interested in that. But my father said, I see your heart. I see how good you are to people. And also, I want you to be an independent woman to feed yourself no matter what. Because back then, my father went through Chinese Cultural Revolution, and he always worried if I was not able to support myself. So I just went to medical school. Actually, that was my father's will. And I became a physician at 21 when I was very young. So I started treating patients. I always had some questions about my patients who come to me and why these patients develop this disease and why this patient's family member did not. Is any pattern, is any lifestyle factors or environmental factors cause their diseases instead of only focusing on treating the patients? Actually, I was very much liked by our patients because I was always thinking and asking questions. So those questions led me to my master program in Japan. That's a community medicine. So I had the opportunity to go to Japan to study community medicine. After my master degree, I became very interested in genetics. So I was wondering what genetic factors can affect people's health. So I became a PhD student in human genetics in Japan.
In Japan. Oh, so you got a PhD and a master's degree in Japan.
Yes.
What school were you at in Japan?
Was in Tsukuba University, which is in a Japanese scientific city, Tsukuba City, nearby Tokyo.
Was that training in English or was it in Japanese?
We read all the papers in English, but when we do presentations and having discussions with our PhD supervisors, also group meetings, we have to speak English or Japanese. But sometimes, of course, we are foreigners there. We mix Japanese and English. Whatever we can do, that we can convey our message. So after my PhD in Japan, I read all the papers in English. Most of them are published by U.S. scientists. So I developed a dream to come to U.S. because I thought that's the top of the science in the world. So I went to National Cancer Institute, Bethesda, to become a postdoctoral fellow, where I had the opportunity to combine my clinical training, my community health training, and also my genetic training during my PhD all together. So because back then, that's the time when genetic variants were introduced to disease studies.
How long were you at the NCI?
I was there 5.5 years.
Wow.
Yeah, that to me is a very critical time for my career development. I had the opportunity to interact with the top class scientists who are using human samples and also epidemiology, clinical data to link people's behavior, people's environmental exposure, and also their genetic background to their disease risk.
You came to Northwestern in 2007, and you built your research program focused on early detection and prevention. What were you hoping to accomplish when you first arrived?
After my training at NCI, I felt I was ready to develop my own career, to become an independent scientist, to answer the scientific questions I always wanted to answer. So I had the opportunity to join Northwestern as a junior faculty. I started applying my own grant by using my own scientific ideas, and I have to, of course, reach out to develop my own collaborations and to find my own research resources that really help me to develop my own independent scientific career. And so in 2008, my father, who was a heavy smoker, developed lung cancer. That really made me more determined. I want to go into the science that will really help us to understand how environmental exposure or lifestyle factors can affect our health, and in particular cancer development. So I started doing my research on epigenetics instead of only genetics, because epigenetics is the field that studies the interaction between environmental factors and our genetics and how they can together affect our health outcomes. So I started working on my epigenetic projects. And Rob, that's when you invited me to go to Africa. That changed the whole my research portfolio by expanding my research into global oncology.
That was a nice shift for you and for us, of course, to get your expertise translated globally. Today, you're the director for the Center for Global Oncology here at the Havey Institute for Global Health. And when you look at cancer globally, especially in the low and middle income countries, what gaps in prevention and early detection concern you the most?
Rob, as you know, we have been working towards the cancer prevention globally. So I think in low and middle income countries, their challenge is access to the innovative advanced technologies that we are using in US for cancer prevention and treatment. That also makes the cancer prevention much more important to join the efforts between us and our LMIC partners, because prevention costs much less and many things can be done if we done it correctly and timely, even decades ago before the cancer prevention. So that's what I feel is the gap. Is there's knowledge gap, of course, systemic gap, and also financial gap. But as scientists, I always say we cannot change everything, but we at least we can do what we do as a scientist. That's to work with our partners in LMICs to develop right strategies, and by providing the scientific evidence to the policymakers, to the government, to see what we can do together to do the cancer prevention effectively. And also, we have been working together not only among our center members, also by collaborating with innovative technology center team members, and also with reaching out to any industry and that have affordable, easy to use, implementable technology for LMICs to use. In the meantime, we also do implementation studies to understand the barriers or facilitators that can, implement WHO recommendations. For example, cervical cancer screening recommendations has been changed by WHO from the VIA to HPV DNA test.
That's great. Your global health projects span several countries, including research, training programs, and cancer prevention efforts. Can you walk us through the major global health projects you're currently involved in today and what you're trying to accomplish?
Yes, the Center for Global Oncology actually initially majorly focusing on West Africa, in particular two countries, Nigeria and Mali, because of the long-term partnership thanks to you, Rob, and for the opportunities, also the research capacities you as a pioneer has built for us. So we set up our NIH-funded Your One on cervical cancer screening and also our one oral cancer studies. And in the meantime, we also established our mobile clinic network in these two countries. However, our efforts to expand our influence, our impact, also our work in Africa has never stopped only in these two countries. So we expanded to several other West Africa countries, including in Ghana, Burkina Faso, and
In Senegal.
Senegal, yes. And in the meantime, we expand our network to East Africa countries. Now we are in Kenya, we are in Tanzania, Ethiopia. So now we are not only working in Africa countries, we have also expanded our cervical cancer research and also breast cancer research to several South America countries, including Chile, Argentina, Colombia, and Mexico. So these new initiatives are still in their infant stage because we want to really establish solid collaborations instead of rush into any immature collaborative relationships. We are going slow at the beginning, but I have a good feeling that all these initiatives will lead to a bigger achievements in the future for us to really fulfill our mission, that is global cancer prevention.
It's really great to look back at the history that we have here and that it really started in the late 1990s with a focus primarily on HIV. We were very much involved with PEPFAR. I was the country director for Nigeria, but we had our footprint in Tanzania and Botswana, and we evolved through the years to the point where we can actually include cancer prevention and even some surveillance and treatment as well. It's really been an incredible story. Let's talk about the focus of your work. You've mentioned it already, but I think it's really so fascinating. Much of what you're doing involves biomarkers and early detection. How do you translate discoveries from the laboratory and population research, which you're so good at, into tools that can be used in resource-limited settings?
So first, my research focus on using white blood cells, but also that has limitations because epigenetic biomarkers are tissue and cell specific. And so sometimes when we find some significant biomarkers, we don't know if this biomarker is tissue specific or cancer specific. So we shifted, Rob, if recall our youthful project in liver cancer using circulating cell-free DNA for our liver cancer biomarker development. This will help us to really use one drop of blood in the end to detect if this person has a higher risk for certain cancers. So we have been using the circulating DNA several years ago when people were still in LMIC using the whole blood doing genetics. We are very ahead of the game. And that study has led us to several very high impact publications. And I think our next step is really working with industry, also even our own Northwestern collaborators with different expertise and science focuses to develop these biomarkers into an affordable, easy to use technology that can be brought back to our LMIC partners. So I think that's the way to go. And also in terms of the cervical cancers, because the tissue is so accessible, because we are not only using biopsy or tissues, we also using swabs because it's non-invasive and also we can easily get the samples. If we can establish some biomarker assays, that can be easily used non-invasively to detect cancer patients at a very early stage, because the earlier you diagnose them, the better treatment outcome the patients will get.
Yeah, I understand that the focus on that West African cervical cancer screening program is actually the specimens can be collected by the patient.
Yes, so that's another thing. As I mentioned, the WHO has recommended, even the U.S. Cancer Society has made the recommendation to use patients' self-collected vaginal swab for their HPV test because a certain HPV virus strains cause cervical cancer. So if we know who have this viral infection, that means we will know they are at high risk and we can monitor them regularly. So to, if they develop into cancer, so we will know at the very early stage and then intervene. So that's something we are also doing in several Africa countries, as we just mentioned.
I think it's really very unique for you as a medical researcher and cancer prevention specialist to go from developing molecular biomarkers to an easier collection system that lowers the price and makes things much easier. And then finally, to get that process out into the field with these mobile clinics that you're working with that were generously funded by the Flanagan Foundation. It's very few people actually have that span of that portfolio in the same area. Can you comment on that? How did that even happen? How does a person actually do all those things?
Thank you, Rob. Our mobile clinic actually is developed out of all our previous interactions, also local partners, and also through the challenges we had faced during our conduction of our previous studies, because many women who live in underserved communities in Africa, they basically have no access to medical care, health care, and not even mentioning that they have access to any preventive measures. So we have learned that, so for us to reach out to them, to go to their community, instead of always ask women to come to the clinic. Some women, they can't afford to come to the clinic. There is also cultural barriers. If they come to visit the doctor and their neighbors, their families would suspect if something went wrong with this woman. When it comes to cervical cancer, is sexual activity related disease that can be also backfire to this woman, affect their life in their own community and their family. So we have been communicating with several foundations. After we had discussions with Flanagan Foundation, they really liked our idea to fund us for 2 mobile clinics, and we made this mobile clinic that really can be even used on very rough roads. So that enabled our team to go to those undeserved communities to have a woman exam, screened. We carefully designed the track so the women who are positive for certain viral infections were not seen by their friends, by their own communities. They do their own sample collection on the bus. We test their viral infection status on the same bus. Also, we treat them if they are positive, and then we examine them first if they need to be treated, and they will be treated on the same bus. That has been a very successful action that I think I will feel proud for the rest of my life, also all our team members.
I have one last question for you, Lifang. I ask to everybody that I interview for this podcast series. What advice do you have for young people who are just now embarking or wanting to embark or thinking to embark on a career in global health? It's a challenging time, as you know.
Yes, I would say never give up. The future sometimes looks uncertain, but please don't give up your dream. When I was a little girl, I wanted to be a journalist, as you mentioned, because I want to make impacts. That's the way I thought I would be able to make impact. So I went to the medical field because my father, but in the end, I think I linked my own dream with the dream my father had for me, and I make it happen. So my advice is never give up making impacts on the society, on people. That will be your drive, and then you will succeed.
Well, thank you very much, Lifang. It's been really a pleasure. I know more about you now than I ever did before, and I know you pretty well. So thank you very much for joining us today and telling us this remarkable story.
Thank you, Rob, for having me.